I call upon my dear friend and colleague, Dr. Omkar. Dr. Jeff will demonstrate extensor tendons on him. You be seated there, Dr. Jeff. Dr. Omkar will come. So, Dr. Omkar and Dr. Manish, my very good friends, have agreed to be a part
Have we got that pack
of this workshop.
Yes,
Omkar is a
yeah.
plastic surgeon.
Here we have. Who does ultrasound regularly in their clinic? Put your hands up. Okay, absolutely. You're going to look at me at a different angle. If you've got a Mohit Shah, you can trust him. But most of them you can't. Okay, it's just a sonographer running the thing over the structure and you get a report. So I'm just a normal hand surgeon. And I'm just going to show you how I look at things. I found the ultrasound. I'll give a talk later on. We'll just get on to the extensor tendon. Let's have a look. Where's my little tech? Is she around? Yeah. So the extensor tendon is one of the most useful things that I find is mallet fingers and boutonnières. And I actually feel very, very uncomfortable when somebody comes in with a swollen finger and the x-ray is normal, and we all know that these things can collapse into a boutonnière deformity or a mallet deformity, either very slowly sneak up on you, or they can be very rapid. When they're very rapid and you've got a boutonnière deformity and within hours, you know you've got a problem, but it's the ones that sneak up on you. So I just love looking at these things all the time. So here we are. So the first thing is to get orientated. And I think I've got a 24mm project. And here, look, you can see the, thank you for your finger. You can see, look at the accuracy. This is a beautiful machine and a beautiful probe. You can see the terminal phalanx, you can see the nail, you can see the germinal matrix, you can see the distal interphalangeal joint. And as you bend, you can see the extensor tendons intact. So somebody comes in with a mallet finger, it's all over and done, baby. You know exactly what's going on. And what's more, it picks up the very tiny fractures that you can't see on X-ray or CT. So then this is the next one, this central slip over here. If we come over here, there's a PIP joint, and as you bend, you can see the central slip's intact. And it's just so easy. I'll talk about it more in my talk, okay? So as we come up here, there's the central slip, that's the central extensor tendon over the dorsum of the MP joint.
You were in the longitudinal orientation,
yes,
and you just switched
yeah.
to the transverse, I think.
Oh, okay. Thank you. There is nothing better than somebody that asks you a question that helps you explain what nobody can understand. Thank you. I love you to pieces. All right. This is a longitudinal structure. And Dr. Shah was saying if you stay longitudinal, I'm at the distal interphalangeal joint now, okay? And you stay longitudinal, you see, you get the best reflection. Now I'm going transverse. Okay, and I think Sudhir is saying, give us a transverse view too, huh? Let me have a look at both views. Just don't look at it one view. I'll tell you a bad joke about that later. It's not funny. Okay, so there is the central slip. And you can come across and you can see the joint across here and back here. And I just find that just so useful. And it has changed my practice. If I get an acute central slip, I put a stitch in it under local anaesthetic, and the boutonnière goes right in front of your eyes while they move it on the table. And that splinting stuff rages and not knowing, that's not cool, okay? And here's the extensor tendon on the dorsum at the MP joint. And then you can follow that all the way back up here. And the easiest place to start up here is to find your, wait till I find it. There. What a view. This is a nice machine. And it's really nice because it's a nice probe. What's your name? So he's making sure I've got the right gear, because if you've got all the gear and no idea, you're going to see nothing. I can't tell you that more. If you've got all the gear and no idea, you'll see nothing. So one of these sitting by is very, very good, thank you, okay? So there, look, this is always a good landmark, the Lister's tubercle, and look at that, we can follow the extensor pollis tent all the way down. And then if you come across here, yeah, thank you. Not only is she excellent, but she's actually doing everything for me. I have a clinic like this. I have clinic pilots and they do everything for me. They have the machine set up, I just wander in, I sit down, they clean up. Look at this. This is the first extensor compartment into Quervain's. Baby, look at that. You can see separate subcompartments, different sheaths. You can actually see this almost the same as a trigger finger. See, you can just see it there. Lift your thumb up and down. So when they get into Quervain's, you can see it triggering like a trigger finger. And then you can wander up all the extensor tendons. And I just, the best one for me that I use all the time, I mean, look at that, extensor digitime minimi. You guys getting excited? It's a nice machine. So if you lift your arm up like this, best way to do this, I'm really sliming you. You're going to hate me. Don't put your fingers in your mouth after this stuff. It's foul. It really is foul. So wash your hands. Okay.
No, I used to do it in my OT itself.
You come forward a bit.
Yeah.
Now, so this is a little bit more difficult. If I could have some on this.
Jelly tunnel.
So which probe do you reckon I should use? That one on this
So
one?
I can use this one also,
Yeah.
2H14.
Yeah, let's do another probe.
Yeah.
Look, I can't, I'll give you a talk later, but extensor carpi ulnaris instability, you can miss that so easily. Jesus, put the probe on if there's any doubt whatsoever, okay? And you'll see, and then compare it to the other side. Because the biggest problem I see is surgeons operating on a physiologically normal unstable ECU. Then they really make a mess because they miss the stuff underneath, okay? So we come up here, there's ECU, that's the ulnar, and you supinate like crazy, and you pronate, and you can see the thing start, oh, look, he's got a little bit of instability. That's normal. If you pop him on the other side, it's probably going to be the same. So look, I'm just a normal hand surgeon. I'll give you more of that in the talk. I can't live without this. And I'm not going to give you a lecture on how to do this. You saw how good Dr. Shah was. Where's Dr. Shah? Guy's a genius. I've been trying to get in the DAUJ for ages. I'm going to have a toot from you later. Because, look, the ability to see, when we understand EC, we're talking extensor tendons again, but the ability to see the pathology in the triangular fibrocartilage, the anatomy's wrong in the books. It tears off the volar part of the ECU sheath. These guys are seeing it. We just got to catch up with them. And it's like Sadir said, you know, blow them MRI. It's coming, it's coming. So thank you. I hope that helped. If anything, I just hope I infected you. And I will say, there's a standoff pad you can get for this where you can put it on, where it's much easier to follow it without losing the contour. And the other thing I'd tell you is, when I started, I had to put blocks in, and in my clinic, and I have ulnar and median nerves all the time, and I was so scared, I got the best machine I could get. And the one bit of advice I'll give you, and in our country it's not cost effective, but if you can afford it, don't buy a fancy car, buy a really good probe and a machine, and get somebody like this to teach you how to use it. Thank you.
Thank you. Yeah, Dr. Ashwin Lavande will show us
After you, sir.
the carpal tunnel, which is very common here.
While Ashwin is setting up, I have a question for Mohit. Now, the probe you said is between 2 and say 17 or 2 and 24. When you're using the probe, does it use all those frequencies, or is there a way of increasing, going from down to up and up, down?
You can actually change the frequency of the transducer. So that is the idea of having multi-frequency transducers. So in the same probe, if I feel I need to go deeper down, I can just decrease the frequency and increase the penetration. And that's a distinct advantage that we have. Yes, yes, yes.
Hello, can everybody hear me? Yes. Okay, great. So now I'm scanning on a Samsung RS85 Prestige machine. It's their flagship machine, and I'm scanning the carpal tunnel with a probe which goes from 4 to 18 megahertz. Okay, so now before, make a focal spot 1. So before starting, what I'll show you is on the probe, when we use the probe, this is a linear array probe, so it has a cranial end and a caudal end. So cranial end will always have a marker, and it will be marked by something, some prominence. So this is the linear thing, which is the cranial end, and that's the caudal end. So if I have to scan it craniocaudal, it should be like this. And when I turn the probe transverse, it becomes in this fashion. So my cranial end becomes the right, caudal end becomes the left. And when I put this pointer on the machine, can you see the pointer on the screen there? This Samsung RS85 which is written, that points to the cranial end, or the one which is on the right side. So if I turn the probe transverse like this, my right will become left and left will become right. So this is the first principle when we are scanning. So when I have the probe like this in my hand, and there is a gel here which is on the other side. So this is the caudal end of the probe because it's not near Samsung. So if I put the gel here, this is the cranial end. Now once I put the gel or the air goes away, air is bright on sonography. And you don't see anything below the air because it shadows. So now we start. Is the image bright, Mohit?
No, barabar.
Wait.
No, this brightness is better.
Okay, so now we start from proximal to distal. My probe is in the transverse plane. So if I move towards the right, you will see the structure on the right, that's the radial artery pulsating. If I move towards the left, you will see the structures on the left, and that's the FCU there, and the ulnar artery pulsating.
When you say you're moving to the right, you are actually moving to your left.
Yes, yes. So I'm moving to the patient's right, okay? My probe is on the patient's body, so whatever I'm telling is in relation to the patient. Remove the tint. Yeah. So now I'm increasing the depth, and you will see some focal spot here. So when I take the focal spot down, I get better penetration. And I decrease the depth, and I see the distal radius and the distal ulna, and this is my pronator quadratus. Please don't. Okay, so this is the pronator quadratus. And when I do pronation, supination, you can actually see the movements of the pronator quadratus. This is the entire bulk of the flexor mass. You see the distal FDS and the FDP tendons forming within the muscle. And if he moves his thumb, just move your thumb, dear. So that's the flexor pollicis longus distal muscle tendon junction. This is the FDS. This is the FDP. And you can see the median nerve becoming superficial. Median nerve is always between the FDS and FDP, and as you come down, you see the median nerve becoming superficial. Now, to see the median nerve fascicles well, I have to take the focal spot up, I have to decrease my depth, okay, and I have to magnify the image a bit so that you see the fascicles within the nerve. Now, can everybody appreciate, you see multiple black dots within the nerve. So these multiple black dots are nothing but the nerve fascicles. And intervening the fascicles, you have that bright echoes, which is nothing but the perineurium, and the entire nerve is covered by the echogenic layer or the bright layer. Echogenic means bright layer of the loose areolar tissue, which is the epineurium. Now,
Can you contrast that with the tendon?
yes.
How does the tendon look as opposed to how the nerve
Yeah.
looks?
So now here it's seen very nicely. I decrease my zoom. And now what you can see is that's the nerve. This is the tendon, the FDS tendon, which is next to me. And these are the lowermost muscle fibers of the FDS. So now you see the muscle is the darkest. Then you have the nerve, which is having light and bright echoes. And then you have the tendon, which is the brightest. And this is the bone, the distal radius, which you see here, which is the most bright. So when you turn your probe 90 degrees and see the muscle tendon, that's the tendon which is forming within the muscle. And when he moves his fingers, you can see the nice motion of the FDS and the FDP. So one on top of the other, and if I go more radially, you will see the nice median nerve becoming superficial as it enters the carpal tunnel distally. And right on top of the median nerve, you see another tendon, which is your palmaris longus tendon, which is like the God's gift when you need a graft. So that's the palmaris longus tendon. This is the median nerve. That's the FPL tendon lying on the distal radius. And this is the FCR tendon, which goes outside the carpal tunnel as you enter it. This is the radial neurovascular bundle, and the superficial radial nerve has already crossed over to the radial aspect as it comes in the distal forearm. So as I go distally now, we see the boundaries of the carpal tunnel, for which I will increase my depth, take my focal spot down, and I'm specifically using this probe for better penetration. So when you see the carpal tunnel, I will make a trapezoid and increase my side view so that I'm able to see the bony landmark. So this is my pisiform on the ulnar side, which is the bony landmark of the proximal carpal tunnel, and this is my scaphoid here on which the FCR distal tendon is located. And if you see this thick band of tissue, which is coming from the pisiform and going all the way and inserting on the scaphoid, is your flexor retinaculum. So the flexor retinaculum starts here. So technically, your median nerve is superficial here. This is the fascia here, which is not the flexor retinaculum. And as you go down, this is still the fascia. Now the flexor retinaculum starts. That's the ulnar nerve and the artery in the Guyon's canal. And as you go down, you can see the retinaculum becomes thicker and thicker. So if this is the pisiform, you go straight down caudally, and you'll get another bony landmark, which is this one here. That's the hook of Hammett. So hook of Hammett and tubercle of trapezium are the lowermost, distalmost bony landmarks where the retinaculum becomes even thicker. You see the median nerve nicely located there. That's his FPL tendon, and these are the rest of the flexors. So now you move your thumb, please. So you can see the movement of the FPL there. Now you move your other fingers. So these are the other tendons which are moving, and the space between the tendons should not be occupied by any hypoechoic tissue. If you see a hypoechoic or dark tissue between the separating the tendons, that is flexor synovitis in the ulnar bursa. So this is your ulnar bursa in the carpal tunnel. That's your radial bursa encasing the FPL, and that's the median nerve which is not getting flattened and going all the way. Now this is the hook of Hammett. So distal to the hook of Hammett, you will see the nerve trifurcating and forming the common digital nerves. So these are the common digital nerves here, for which again I remove my trapezoid, increase my depth, decrease my depth, and the focal spot comes there. So that's the median nerve complete throughout the tunnel in the short axis. Then I turn my probe 90 degrees, and now you see the fascicles, which were like black dots, have elongated and formed nice elongated nerve fascicles. This is the FDS, that's the FDP. I increase my depth, so you see the volar wrist joint recess as well. So this is my volar wrist recess, median nerve, flexor tendons, and this thick band-like tissue on the top is the flexor retinaculum. So now you move your fingers. So now you can see how the tendons move, and the tendons are brighter as compared to the nerve. You go distally, the nerve trifurcates here, and that's when the nerve disappears, and you see only the tendons going distally into the ulnar bursa. So as you go into the palm, the median nerve has already trifurcated. That's the ulnar bursa with all the finger flexors, and that's the ulnar artery which is giving the superficial palmar branch and kind of forming the superficial palmar arch. So this travels over the hook of Hammett. So this is the hook of Hammett, that's the superficial palmar branch of the ulnar artery. And then you can actually see the nerve fascicles beautifully. You can trace it behind. So this is how we look out for carpal tunnel. So what we do is, we go where the pronator quadratus starts. We freeze and we take the cross-sectional area. Wait. So I will take my first cross-sectional area here where the pronator quadratus starts. It's around 10 millimeters square or 9 millimeters square. I come distally, just proximal to the retinaculum, where it starts here. I go behind where the nerve is slightly superficial. and take my second cross-sectional area here. So that was 10, and this is 11. So that means there is not much difference. And I again go distally, and just before the trifurcation, I will take another cross-sectional area here, and I will see where the nerve is getting enlarged. If the nerve is getting compressed in the carpal tunnel, then I won't see any much difference in the cross-sectional areas. If it's getting compressed, then it will get enlarged proximal to the tunnel, and this difference as compared to the distal forearm will be significant. And then what I do is, as I go into the mid-carpal tunnel just above the hook of hamate, I will freeze my image here, and I will measure the transverse diameter of the nerve divided by the AP diameter and see for the ratio. Now this ratio, we all know this is less than 3. If it becomes more than 3.54, that means the nerve is getting more and more compressed. So this is like an ancillary and additional finding and confirmation that yes, your nerve is getting compressed, it's getting flattened. And last but not the least, what I'll do is I'll keep the probe on the thenar muscles and see the quality of the muscles at the thenar eminence. So this is my FPL tendon. When he moves it, you can see, and these are the nice thenar muscles, the flexor digitorum brevis, the opponens, and the abductor pollicis brevis. So all this you can nicely see here. And this is your first metacarpal. Sometimes we don't see the single trunk of the median nerve, but you see a bifid median nerve. That is the time when you do normally a persistent median artery follows, and it will be between the two trunks and go into the carpal tunnel. Last one structure which I need to show is, whenever we do a carpal tunnel release, the retinaculum is kind of released more on the radial half of the tunnel, just next to your distal FCR. And can you see this black dot here? Wait, don't do anything. Can you take this image down? It's not coming down. No, it's okay. I'll do it. It's okay. Can you see this black dot here coming? If I'm tracing it proximally, it's going down, it's going down, it's going down. This is the FCR. It's going down, and then it's going underneath the FCR and going and attaching to the median nerve trunk. So that's my palmar-cutaneous branch of median nerve, which comes underneath the FCR. Sometimes it travels distal to the FCR, and if I'm tracing it, it goes superficial, and then finally superficial to the carpal tunnel there. So this is my flexor retinaculum, and that's the palmar-cutaneous branch. So if I have to tell you that, yes, your palmar-cutaneous branch is around 2 millimeters from the median nerve, then when you're doing a carpal tunnel release, you'll be in a better position to save this, because that is one of the commonest causes of significant increased sensitivity when you do a carpal tunnel release.
The recurrent branch also. The recurrent branch, can you see it?
The recurrent branch, unfortunately, is difficult because that motor branch you're talking about.
Yeah, the motor branch. So you can't.
No. Motor branch you cannot see because it takes. I'll tell you, this is the median nerve main trunk, and as you go distally, this is the place where it trifurcates. This is the place where the recurrent branch comes and goes into the thenar eminence, and it's really difficult to identify. So we never even think about searching for it.
This is really very, very topical. Because 1 to 3% of patients are going to have a variation in the motor branch where it's dragged radially and crosses across. And you talk to that. Thank you for that very honest appraisal, because I've been looking for it all the time and I can't get it all the time. Then I talk to these other people and I feel like I'm really incompetent. But the reason for stressing this is we're all moving into ultrasound guided release. It's a very good operation, carpal tunnel, with very low complication rates. And the other question is, can you see the motor branch of the ulnar nerve?
Yes, very much.
Yeah, could you just show us that?
Yes,
I would
please.
really love to see that.
Yes, please. My pleasure. Since the topic was only carpal tunnel, I didn't want to go away from it. So now since we are talking. Thank you, sir. So now if we can appreciate this, that's my main ulnar nerve trunk. Okay, I take my focal spot down to see the nerve better. Actually, the machine has factory presets.
Can you just tell us what this focal spot is?
See, this is, can you see the arrow here on the screen?
Yes.
Okay.
Huh?
Now the thing is, the place where the arrow is there, your machine will concentrate and focus the ultrasound beam sharper. So I'll see the nerve better.
Right.
If I take my focal spot down, the nerve will become more blurred. See that?
Okay.
If I take it more higher up, the nerve will again become blurred. So I take
Okay.
it at the place where the nerve is, and this is the place where you can see that the nerve is nicely seen underneath the FCU muscle, ulnar artery, ulnar nerve. Now at this level in the distal forearm, if you see, a structure is given from the main ulnar nerve trunk here and going here, that's your dorsal branch of ulnar nerve. Okay, this is your dorsal branch of ulnar nerve. You can see those fascicles going between the FCU and the lowermost FDP muscle. Okay, so that's the dorsal branch of ulnar nerve. If I come further down, this is the main ulnar nerve trunk. And what I'm going to do is, I'm going to magnify it a bit. And then I come here, you can actually see the ulnar nerve coming here. Then going further, this is the ulna, the distal ulna, which you can appreciate. That's the ulnar nerve further coming here. Now I'm coming near the pisiform. So this is the pisiform. The ulnar nerve is going into the Guyans canal. It is still a single trunk. And then as you go distally, you see that it's dividing into two. That is the ulnar artery. This is the sensory branch of the ulnar nerve, and this is the motor branch. Again, I go proximally, it's a single trunk. I come distally, this is going away, this is going away. Now concentrate on this because this is the hook of Hammett here. And my focal spot is here. So I'll take it down. Image is more clearer. I see the hook of Hammett there. And you see this particular dot. This is the hook of Hammett. So dot, dot. And then now it turns here. It winds around the hook of Hammett here. And if I have to see it clearly, I have to angulate a little bit into the palm so that as it winds around, this is the hook of Hammett. That's my motor branch of ulnar nerve. You can actually see it going into the palm there. So that's the motor branch of ulnar nerve. And this is the place when you have these degenerative changes in the joints there. The nerve gets impinged here, and that is where you have the selective paralysis, motor paralysis in the ulnar nerve distribution, where the nerve gets impinged here. So that's the motor branch, proximally tracing again to the main trunk. And that's your entire ulnar nerve in the Guyans canal. This is the sensory branch going on top. And if I angulate my probe a little more medially, this is my motor branch going lower down. But I think it's better to trace it in the short axis. You see it nicely winding around the hook of Hammett, which is this one. That's the motor branch. That's it, sir.
Amazing. Just one quick thing. The vessels, you see them pulsating. You see the artery pulsating. Could you show us the flow? The color. We just love color.
Sure.
Sir, and one more request. Can we see perforators, like we have pedicle flaps on the ulnar side and perforator based?
Okay, so that's the, again, focal spot at the place where the artery is there.
So you got to make some adjustment
Yes.
on the machine.
Increase
so
C.
that,
You have this button 2D and you have to see. 2D means 2D gain. If you want to increase the brightness, you increase the 2D brightness, decrease it optimally. You can't become too dark. But every high-end machine nowadays has a one-touch optimization button, and there is called as a Q scan here. So I just press Q scan. Wait. Just press Q scan, and it becomes automatically slightly brighter. But I want. See, we are all started using machines when it was 20-year-old, 25 years old. So we are used to all those manual cars. We like those manual 4x4s. We don't like these automatic 4x4s where you just press the button and it goes into that particular mode.
It's like a good photographer. He wants a manual liker.
Yes. What were you saying?
The vessels.
Vessels.
Just,
Okay,
just
so-
the flow in a vein and in an artery, just the difference between the two.
Okay, so I think radial will be better. So first of all, that's the radial artery. You see the deep veins of the deep radial veins next to the artery. So you just compress and see. So the veins wink like an eye, but the artery will never get compressed. So that's the first thing. Before even putting a color Doppler, I go to the radial side, and that's the cephalic vein. So typically when you do a decurvance release, what we see before telling you that it's a thickened retinaculum, we go here and we tell you that yes, this is the compartment 1 tendons, APL and EPB, and this is the cephalic vein which is getting compressed, and that's the superficial radial nerve, the 2 fascicles which you can beautifully see crossing over the compartment 1. So they have already crossed, and then your extensor retinaculum is there, so you are safe. Your volar branch of the superficial radial is on the volar side, and your dorsal branch is on the dorsal side, and you can see it beautifully crossing over after the bifurcation. So flow in the cephalic vein So you have to adjust the settings. This is on the very low flow, and she's steering the beam. So you steer the beam according to the angulation of the artery, and you see the flow in the vein. It's a very slow flow. It's like a slow flowing river. And when you put it in the ulnar radial artery, you have to increase the 2D the scale, so that you don't get any mix-up of colors. You get proper colors, which we call as aliasing, and you can see here. So typically when we put a pulsed wave, this gate should be small, and we change the angle so that according to the direction of the flow, so you get the correct velocities. And then when you put the Doppler, volume, so this is how a peripheral artery will appear. It's like whipping of a horse. Okay, so this is how the pulsatile flow triphasic waveform of the artery will come as you take the flow. So this is how we differentiate between an artery and a vein. But if the same thing, if we take in a vein, I'll take the radial vein only, and I'll decrease the scale to absolutely low, and you see the blue flow there. So whatever is red is coming towards my probe and going into the palm. That's why it's red in color. Whatever is going away from the probe and up to the heart is blue in color. That's the vein. So that's the spectrum which you get of the vein. It's like a smooth flowing river. And you'll see when my gate always goes half in the artery and half in the vein, I'll get this mixed kind of a spectrum. That's it, sir. Thank you.
That's absolutely fantastic.
Dr. Lee,
Thank you.
Dr. Lee will demonstrate the flexor tendons, and then we will ask some questions from delegates, and then Manish will come as a...
Amazing, wasn't it? Yes, okay. That's one tough act to follow. Thank you very much, Dr. Ashwin. Okay, my name is Ellen Lee. I am not a sonologist. I'm a hand surgeon. I run a clinic where each patient has about maybe 10 minutes, 5 to 10 minutes to see each one. The machine is there. It's not as pretty as this one, but it's usable. Probes are usually from like 6 to 18, right? And it's just there for use. There's no Wonder Woman sitting beside you to check your gain, change your focus, and all that. So you have to do everything yourself. So regarding flexor tendons, the most useful tip I got was from Professor McGrowther. He taught me to get a basin of water and put the entire hand inside, so that, you know, prevents the goop from going all over the place. And also for fingers, it's very narrow, right? So the gel tends to fall on the waist side, and then you will lose your view. So I found that very useful. It's just very tedious to keep changing the water and cleaning the basin between, you know, each patient. So And then the other thing that I find useful is, yes, for a hand surgeon, you have this knob in here, and I just keep track of where it is. So usually I don't know where it is, so when I start, I just put my finger over there, and I see where it is, and I just try to remember if it's my radial, or towards the thumb, that's where it is, and if I keep it distal, that's where it is also. That's how I, organize the information in my head. Okay, we're supposed to do the fingers now. All right, so for the finger, right? Yeah, we're supposed to do flexor tendon in the finger. Yeah, maybe shall we do the smaller one? Yeah. So the bone is my friend. That's the first thing I learned. It's easy to see. Okay, here we go. It's easy to see the bone, right? And we all know anatomy. So currently the knob is to the distal. And then, so we start with the distal. We can zoom out a bit, yeah. Okay, so that shell, this is on a longitudinal view with this being distal. So that's the bone, and you can clearly see his flexor tendon. I always start distal because I know there's only one tendon there, right? That's the FTP. And it's useful for, if I'm not sure whether they're ruptured or a partial rupture in, climbers. So I start from there and keep track. So you can see his flexor digitorum profundus inserting onto the base of the distal phalanx all the way up to there. And as you can see, my hand is not as steady as a sonologist, but I just keep track of where it is. And that's the DIPJ. You can see the joint, okay? So then as you trace it proximally, so if I use water, it gets rid of all these image distortions because the gel is going away or dropping off. So at this point, this is the PIPJ. You will start to see that you can see the head of the proximal phalanx on a longitudinal view. There's the volar plate, and then the flexor digitorum. This is a really good machine. Amazing, right? Yeah.
It's very exciting, isn't it?
Yes, it's way better than the machine I'm using. No, you can clearly see where his FDS is at the base of the. Yeah. That's really good. Thank you for. Okay, so now you can see the digitorum profundus in the superficial, more superficial, and then his superficialis inserted there at the base of the middle phalanx, and then we go.
Can you show us the volar plate because it's
Yes.
Very beautiful, the volar plate.
Yes, it's an amazing machine. There you go. Then over the head of the proximal phalanx. There.
And can you just trace it a little proximally where it
Yes. Hold on.
inserts? It's really beautiful.
Yes, it is. I'm losing the gel. Yeah, so when you go back, you have a machine, you try it on water. It's really, I find it's quite useful for fingers, for narrow surfaces. Okay, that's the head of the proximal phalanx. That's the volar plate. Let's see if we can see there you go. The tendon is, so the soft tissue, no, that's the more superficial one is the profundus, which is the big, yes, and then the superficialis is behind it, and deep to that is the volar plate, which is a little deeper. Sometimes if I lose my way, I go back to the longitudinal and look for it again. There, right, that's the volar plate.
So you can keep the probe there and just gently twist it into the transverse.
Yeah.
And then you're on the same structure.
Yep, thank you. Doing that as slowly as I can. Did that work?
Yes.
Yes. You can see the cleft of the condyle in there. I can't see the check rein though. When it comes down in two little tails? Can you
Right.
see that?
Ashwin talks about it in his reports.
Oh, okay.
Maybe he'll show us some.
Yeah, I haven't seen that, but this is one amazing machine. All right, then we go back. So that's the proximal phalanx now, right? And now we can see if he moves his tendon and we don't lose sight of it, you will see the superficialis, right, coming on top. Sometimes you can see it on transverse, where the chiasma comes up. See, here it's two bottoms, and then when you trace it, it should like flip up. And the orientation changes. You know, where the superficialis becomes more superficial and the profundus goes back deep. And then and this area you can see is A2. So sometimes I use it also to look at pulley ruptures. And you can see that the flexor tendon is very close to the bone. It gets lifted off and there's some space or fluid, and see tenosynovitis. So now this is the MCPJ, the metacarpophalangeal joint, and over in this, yes, you can. But I use it to see the thicker ones, like over here. Yeah, because a bit more. Okay, I'm just gonna shift your gel around, okay? We're trying to see pulleys, that's why we're back here. Okay, it should be on top of the flexor tendon. So remember they said earlier that if it's 90 degrees to the structure, you'll see it better. So I think with practice, you just sometimes I just changed how the probe is angulated and you can get a better picture. We go back down to A1 first. Okay, it's easier to see. There, that's the metacarpal head, and that's the pulley. Okay, can we freeze that? The pulley should be, okay, usually I see a tendon and it's the thickness on top. So if you're not sure, I look at the opposite side, as they said, and then the one with trigger with the pathology would be thicker. Try to get a better view. But yes, you can see pulleys. It should be that usually it's in front of the head, right? Directly in front of the head. This is the head, right? And then that will be the volar plate, that will be the flexor tendon, and then that black band that runs transverse would be the pulley. And sometimes if you go transverse, you see it like that, but I find it harder to gauge the thickness in this view. So I flipped it over to the longitudinal one. And then also somewhere is, if you have a trigger, you can see a nice pop, but you don't have a trigger. Right? And then by the time we hit this area, it will go over to where Dr. Ashwin was showing us nicely the carpal tunnel. Yeah. That's it. Thank you. There you go. Sorry about that.
So, any questions so far?
Just, can you see the neurovascular bundles at this level also?
Yes, you can. Why don't you, show it.
That would be really good because there's big advances coming in Dupuytren's fibrosis, which you don't probably get much of here. But, needle aponeurotomy in the palm is fantastic. But now they're doing cutting the bands in the finger, and they tell me they can see the neurovascular structures clearly when they're cutting it. So if I could see what you can see on this machine, you would make me very happy.
So they're doing it percutaneous?
Yes.
With the needle?
Band, no, they're using knives.
Oh. So they're using knives, ultrasound guided?
Percutaneous, special knives.
Ah.
I have enough trouble with recurrent seeing the things going
It's just important that we all learn, because that's what's coming in. Otherwise, Ashwin's going to take away all our business.
Okay, so now I'm... Sorry. So this is, I'm in the short axis of the finger, that's at the level of P1, the mid shaft of proximal phalanx. I'm right on top of the A2 pulley. You can see the A2 pulley beautifully there. I go on the radial aspect of his middle finger, and what you see is that's the digital nerve which you can appreciate, and that's the that's the digital artery. I just put a Doppler, and you can see that the artery will show flow, and the vein won't show any flow. Okay, that's the pulsatile flow in the digital artery there, and this is the digital nerve. Okay, in the long axis, if I want to trace it, that's the tendon, the flexor tendons, that's the A2 pulley, and I go on the radial aspect of the finger, and what you can appreciate is that's the digital nerve. I decrease the gains, I take my focal spot up, and again decrease the gains, and that's the digital nerve, which you can appreciate, which has a thickness of almost around 0.5 millimeter, if I can. So that's 0.7 millimeters. And just underneath that is your digital artery there, which you can see beautifully pulsating. Okay? And that's the blood flow. Similarly, on the opposite side, that's the nerve, this is the artery. And that's how you can see the pulley, A1 pulley, where we just measure the thickness and see that it is around 0.3, 0.4 millimeters. Anything more than 0.9 or 1 millimeter, we consider it as a significant thickening, and that's when the triggering happens. So when you have the triggering, you can actually not see the movements. You can see the movements now, and you can see the structure which is moving on top of the tendons. This structure, just concentrate on this structure. This is my A1 pulley, where my arrow is. And he's beautifully moving it, and you can see.
So it is a little hyperechoic.
Yes.
And the volar plate just looked so beautiful over there.
Now you can appreciate, I'll just show you the Chekrian ligaments, which sir was asking. So this is the head proximal phalanx, this is the volar plate, this is the distal attachment, and what we do is we see like this. So you see the distal attachment when my arrow is there, the volar plate is nicely attached there. And then what I do is to see the Chekrian ligaments. See, what happens is when there is a flexion deformity, you are not able to extend the joint like this. You can see the excursion of the plate. See that? That's the excursion of the volar plate. So if that plate is not happening, just take the arrow down on your right. Yeah. Wait. See where my arrow is, just take the arrow a little up, little up, little up, little up, further. That's the Chekrian ligaments where the volar plate proximal attachment is there. Little higher up, higher up. Yeah, there. So this is my Chekrian ligaments, which become significantly tight and scarred in cases of chronic injuries, and that's the time when the volar plate excursion is not there. You can see the volar plate excursion. This doesn't happen. So then what happens is the joint remains in this fashion only with an intact and scarred volar plate and tight Chekrian ligament. Take the arrow behind further on your right. No, on your right. This side. Yeah, there, down, little down. That's the Chekrian ligament attachment on the proximal phalanx. So that's it, sir.
Fantastic. You know, I love the way they say, this is my Chekrian ligament. This is my, it's so personal for them. They are enjoying it as much as we enjoy seeing their reports. Ankit, Mohit and Ashwin send diagrams. I don't even read the report. I just look at the diagrams. It's so beautiful. What is also, it wouldn't make any difference. I want the diagrams. But the other thing is, who's coming in next? I think Mohit is coming next. While he sets up. One extremely important thing that you have to understand is their familiarity with the anatomical structures and the names of the structures is identical to what we think, and their understanding of that is as good, if not better, than us. And that's what separates them from the rest of the sonologists. So you have to go back to your cities, to your towns, to your centers, and get your sonologists to learn the anatomy with you. Only then can you expect reports like this.
Which one is better?
You can just check it.
That's absolutely true, but they see it differently. Yeah, I've got the most incredible radiologist. He got on it 30 years ago, and he sends me videos, so I'm continually learning. And he doesn't make up stories. He tells me what he can see. And what he can't see. Yes, he never makes a story, which means he's never wrong. And because we see it differently. You're right. I'm blown away by their anatomy. A really good person, a radiologist like this, has got anatomy like you wouldn't believe, and they see it differently. But we also have something to offer there that they can't see.
And the reason I say this is because for the first maybe 200 cases, I went with my patients to Ashwin, and I would ask him to show me in his sonology book what images are being seen, and I would show in my anatomy book what I want to see. And our knowledge grew together. And so he knows what I want to see, so does Ankit, because these are my two main persons whom I send. Yeah, because we've been doing this for years and years and years, and we know exactly what we are looking for, and they know what exactly they want to give us. And that really brings out the importance of ultrasound. Mohit?
Yeah.
Yeah. So this is, I think, the most clinching point that he's pointed out. For a sonologist, you have to remember there's a huge learning curve. So knowing from a clinician what needs to be seen, I think that's the distinct advantage that you provide as a clinician. Okay, you tell us that this is what I want to see and this is what is to be seen. In this particular case, makes a hell of a difference to the sonologist, to sort of relate it clinically. And the sonologist who's got that kind of support will always be the best sonologist. There's no doubt about it. And this is where I think that's why Ankit and Ashwin are what they are today, because you have that constant motivation and the kind of knowledge sharing that brings them together. So I'm going to demonstrate cubital tunnel. Ashwin demonstrated carpal tunnel, where you had the median nerve passing through a fibro-osseous tunnel. So when you talk about tunnel, it's a contained space. It's a fibro-osseous tunnel where you have a limitation to the expanse of the contents of the tunnel. So you have a fibrous covering on the top which forms the roof, and that's the Osborne ligament which actually connects the medial epicondyle to the ulna. And then you have the bony base and the medial collateral ligament, the posterior band, which forms the base of the cubital tunnel. So typically when I want to see that, it is the positioning which is very important. So we would like to slightly flex and ensure that the patient's palm touches the table with the elbow which is slightly flexed. And in MSK ultrasound, we always follow the bony landmarks. So fortunately for us, we have the two distinct bony landmarks, posterior-medial to the elbow along the posterior aspect. You have the medial epicondyle and you have the ulna, the olecranon process of the ulna. So once I have identified that landmark, I just need to keep my probe perpendicular to that bony bridge. And I'll ensure that I have enough gel so that I can fill in the trough that is created between the two bones there. So I will keep my probe bang onto that bony landmarks, and you see those bony landmarks. Can you just increase the gains, decrease the depth? Furthermore, slightly, okay, let it be. So, can I have an arrow? So here is that mound of medial epicondyle, and there you have the ulna there, okay? And you can see the ulnar nerve, and that's the major component within the cubital tunnel, and you will see the ulnar nerve close to the medial epicondyle there. And if you elongate and you make it more transverse, you see this thick band of tissue that joins the two bones, and that's the Osborne's retinaculum. Can I just freeze it here? Yes. Yeah. So if I look at the structures here, that's the ulna, this is the medial epicondyle, and that echogenic bundle there that you see is the Osborne's retinaculum. Now this is a thick fibrous band that forms the roof of the cubital tunnel. So this tunnel is formed by this fibro-osseous fibro band, the Osborne's retinaculum on the superficial aspect, and you have the bones and the posterior band of the medial collateral ligament. There in the backdrop, that forms the base of the cubital tunnel. So it is a narrowed space that you're looking at, and therefore you have to understand that anything that encroaches within the space will eventually compress the ulnar nerve and will lead to the cubital tunnel with the compression neuropathy. So once I am there at the elbow, I will see the ulnar nerve there, and you can see the nice fascicles that we can appreciate as a honeycomb structure, and that tells me that the nerve is normal in echogenicity. The moment I feel there is a loss of fascicular appearance means the nerve is now edematous, and the nerve then increases in size. There is an increased water content secondary to edema, and that means there is a neuropathy which is setting in. So in transverse, I have to just ensure that I am banked perpendicular to the nerve at all times, which allows me to interrogate the nerve and appreciate the honeycomb appearance of that nerve there. So when I go up, I have the triceps muscle on the ulnar side and the flexor muscles, and then as I come down, I see these distinct bands of the flexor carpi ulnaris, that is the ulnar head and that is the humeral head. And as I come down further, you find that there is a ligament which joins the two, the arcuate ligament, which overlies the ulnar nerve just below the elbow there, and that is the band between the two heads of the flexor carpi ulnaris. So my objective of looking at the cubital tunnel is to appreciate the compression neuropathy of the ulnar nerve within the cubital tunnel, and for that I will look at the ecotexture, I will look at the dynamic movements, and I will also look at the longitudinal axis of the ulnar nerve as we navigate the cubital tunnel. So to begin, I would like to look at the ulnar nerve as it is closer to the medial epicondyle, and I would like to take the elliptical area, please. And again, like the median nerve, we have size cutoffs for the ulnar nerve. Anything more than 10 points towards cubital tunnel, anything more than 15 is a definite evidence. Whenever there is a compression of the nerve, there is edema, there will be, can you just do that? Yeah. Can you decrease that? Yeah. No, lesser, yeah. So, anything more than 10 fits into, can you just adjust the left end of the, anything that is more than 10 fits into a cubital tunnel, but is not the size criteria alone. Remember that compression neuropathy comes with nerve fascicular changes, nerve edema, and therefore the appearance of the nerve also matters equally apart from just the size. So if I have to see the ulnar nerve, again, ensure that, and I find that the ulnar nerve is showing me a good fascicular appearance, I will now elongate the nerve and see as it courses through the cubital tunnel. There is no narrowing of the nerve, there is no notching of the nerve, and the nerve is easily passing through the two heads of the flexor carpi ulnaris as I move below the level of the elbow, and eventually it will join the ulnar artery in the mid forearm and to continue its trajectory towards the Guyon's canal. But this is the area where I want to look at the ulnar nerve, and you look at the fascicular appearance which is fairly maintained, thereby saying that this nerve looks absolutely fine. I do want to do a dynamic evaluation in flexion, because remember the biomechanics in flexion, there will be a compression of the cubital tunnel because of the compression of the Osborn's ligament, and therefore the space within the cubital tunnel will decrease. You can accentuate the cubital tunnel entrapment by flexing the elbow, and also, in 30% of the patients, including mine, you will have ulnar nerve instability, meaning that as you flex the elbow, it can subluxate over the medial epicondyle, and this per se can be asymptomatic, But over a period of time, frictional irritation can also lead to neuropathy. So we can look at the ulnar now as it seen. Yeah, you could just, this one. Just look at the ulnar now as we flex and extend, and you see that it just subluxated over the medial epicondyle, and that is ulnar subluxation. And this is a very normal finding in 30% of normal individuals, and it is probably asymptomatic, but it's just that when you keep your elbow in a flexed position over the table for a long time, like what I do when I'm scanning, I'm probably too focused, I keep my hand on the machine, and that's when, in that flexed position, when the nerve is subluxated, I tend to develop this kind of neuropathic pain over a prolonged period. So this is one personal experience that I share, but this is how you check for it. And sometimes you have to remember there could be a double snap. Along with the ulnar nerve, you can also have the triceps, which goes along with the nerve over the medial epicondyle. So you can see that in dynamic maneuver. I think that's the most important aspect of cubital tunnel that you need to see. Okay, so it has got, unlike the carpal tunnel, the ulnar nerve is a major content of the cubital tunnel. The other contents are non-conspicuous, a recurrent branch of ulnar artery, it really doesn't matter. But it's the ulnar nerve that we will be focused on, and the bony landmarks are quite easy to point. You see these two bones jetting out when you look at the posterior aspect of the elbow. All you need to do is have enough jelly to bridge on the gap between the two so that you can visualize the nerve. You have to remember that every time you keep your probe in elbow flexion, it has to be perpendicular to the nerve, and that's the better way of looking at the nerve fibers. You see the nerve fascicles very well when your probe is perpendicular to the ulnar nerve, and that's a very reassuring sign. And the os pons retinaculum is seen as a thick echogenic band there, and you can trace it below the elbow when you look at both the heads of the flexor carpi ulnaris there. That's the humeral and that's the ulnar head, with the arcuate ligament bridging the two heads there, right?
Dr. Mohit, can you show us the subluxating link? How much it should?
It should never go beyond the medial condyle. So
can you show the normal?
So look at where the nerve is now. So try and understand the ultrasound image here. I am looking at the posterior aspect. माझी पण आहे ना, हिची पण आहे, ह्यांची पण आहे, हां दाखवली आता कोणाची. So if you look at, I'm just trying to explain the ultrasound image here. I'm looking at the elbow from a posterior aspect here, okay? So this is the medial epicondyle, okay? That's the ulna there, okay? So if you look at it, the ulnar nerve is medial to the medial epicondyle. I hope you're getting it, okay? This is the posterior aspect of the medial epicondyle, and that's the lateral aspect of the medial epicondyle, okay? So ulnar nerve has to stay medial to the medial epicondyle. The moment it comes posterior, or in my case here, on ultrasound, it is here anterior, because I am seeing from posteriorly. I will say but it actually subluxates posteriorly and eventually laterally. So this frequent movement is the reason of your frictional irritation. And as I said, I have a habit of putting this, and that's the reason I have an flexion, protracted pain over the ulnar nerve. So if I look at this ulnar nerve now, and I do the flexion extension, you keep the arrow on the nerve, please. Yeah. Can you just flex it, doctor? I can actually feel the nerve snapping on my transducer. I can feel that snap on my transducer. It's very well, see, you can see it going over the medial epicondyle and beyond. Okay? That's sure shot subluxation. That's a sure shot subluxation. So it's a dynamic maneuver, so it moves as I move the probe. Okay? It goes beyond. Now it's come back again. I've used, yeah, You just move, flex it again. Yeah. Yeah. So the moment it goes posterior to the medial epicondyle and lateral, that's when it is subluxating. So ideally it should be medial to the medial epicondyle, and every point you have to ensure that you have enough jelly there to show the ulnar nerve medial to the medial epicondyle. Flex it again. Yeah. Please do
Can
that.
I ask a question while
Yeah.
you're doing that? One of the hidden ones is the lazy hand. When people flex their elbow, they get numbness.
Yes.
And they have weakness of their intrinsic muscles, even when their elbow's stable.
Yes.
But their electrophysiological study is normal. Frequently, they have ulnar nerve instability. But what I'm hearing from you is you have the ability, the resolution to see abnormalities in the fascicles. Are you able to, because some can be just motor,
Huh.
are you able now to discriminate where people have no electrophysiological studies but have a lazy hand?
So thing about electrophysiology in Mumbai is it's first of all, we do not always get into direct private practice. We never have this direct correlation. And there are very few people who are actually doing good electrophysiological tests. What I'm trying to say here is a bit different. So we rely on the structure of the nerve to gauge
Yes, I
whether
can
the
hear
nerve
that.
is inflamed. But to get the structure of the nerve, we have to ensure that the ultrasound beam, for example here, is perpendicular to the nerve. Now if you see the nerve fibrils there,
Yeah.
but you know I move it up and I'm at an angle to the ulnar nerve there, this is anisotrophy. I can easily make it an edematous ulnar nerve. Okay? So at every time that I am ensuring that I am perpendicular to the nerve and I see the nerve fibrils, I am sure that the nerve is normal. The moment the distinction between the fibrils is lost, the perineurum is lost, means that there is a nerve edema.
Thank you.
And that's the reason why we say that there has to be a neuropathy there.
And by perpendicular, you mean smack right angle?
Smack. That's the
Because
basics of...
they have different languages, you know, offset, onset, this and that. Thank you.
Yeah, that's the
I'll be
basics.
looking very hard now.
Yeah. Thank you very much.
Thank you, thank you. Wonderful. We now have
Thank you,
Ankit to show us the posterior interosseous nerve and talk to us about tennis elbow.
All right.
Yeah,
Yes.
go on.
So we have been listening from all the speakers that this is a wonderful machine, wonderful machine. So what is that this machine has which is wonderful? Is it the pixel quality? Because most of the features look like the basic buttons, the basic probes, what you have been using. It's nothing new. What is it that it is making wonderful, looking wonderful? Or is it the way our radiologists are doing?
We have it 2 to 14.
I think it's worked both ways. First of all, you need good software and good hardware in the machine and the quality of the probe. Okay, so when you get a good technology, then the technique is very important. So it works both.
Can I ask a question? These are expensive devices. They cost a lot of money. They take a lot of space. And I would ask you, I mean, this is a bit like a musician. A musician can make a bad piece of stuff sound good. Do you wander around trying all these machines and which one you want to get next time? Is that what happens? And we'll ask you outside what your favourite one. That's a very nice machine.
Sir, to be frank, these machines are flagship machines, so they cost anywhere like the luxury cars. So we cannot drive luxury cars in our city because of the clogged roads, but at least we can invest in these machines and enjoy some good work.
Single focal zone.
But you skillfully avoided the question. I'll catch you after.
Okay, great. All right, so good morning, everyone. Thank you for the warm invitation. So just like what Dr. Lee, Dr. Mohit Shah, Dr. Ashwin mentioned in the morning, the principles for musculoskeletal ultrasound is you need to be aware of our bony landmarks, the osseous landmarks. They're going to be our friends while scanning. So that is one aspect. And as far as peripheral nerve imaging is concerned, we as radiologists, we are taught to look at the nerve in the cross section. That means if the nerve is elongated, we would like to see it in sections. That is, we will be seeing the nerve as a round structure, all right? So it's known as an elevator technique, how to evaluate the nerve. So once you just identify the nerve, let's say this is the posterior interosseous nerve. Once I have identified it as a round structure, what I'm going to do is I'm just going to go up. Okay, I can go all the way posterior in the region of the spiral groove, and I can go all the way down. So this is also known as an elevator technique, all right? So once again, when we look at the nerve, we've all heard in the morning, what the normal nerve looks like on the cross section. So what I'm going to do is I'm going to adjust my depth a little bit, and I'm going to get a good picture of the nerve. So first, I'm going to look for my bony landmarks, and this is a humerus which I'm looking at. So if you're not certain, which bone you're looking at, you just put your probe along the long axis of the elbow over here. You identify your bony landmark. That's your humerus. That's your radius over here. All right. So once I've seen the humerus, I'm going to turn my probe horizontally, wherein this is going to be the radial aspect and that's going to be the ulnar aspect. And this rounded structure which you see over here, this is the capitulum, all right? So that's the capitulum and that's the articular cartilage over here. Now, once I've identified the capitulum, that's my bony landmark, I look at the muscles, all right? So in the previous talks, we looked at what the muscle typically looks like. It has what we describe it as a starry night pattern. Starry night pattern means, it's based on the Van Gogh's painting, wherein, he uses these brush borders to make the stars. So this entire thing is a night, and these are supposed to be the stars, the connective tissue in the muscle. So this muscle is the brachioradialis along the lateral aspect or the radial aspect, and over here, this is the brachialis muscle, all right? So between the brachialis and the brachioradialis, what you have is this echogenic or this bright triangular area, that's the fat plane. And within the fat plane, what you see, this dot over here, that's the radial nerve which I'm looking at. So if you want to look at the nerve, what you can do is, it typically has a honeycomb pattern or a fascicular pattern, all right? So as I go proximally, this is the radial nerve, which I'm tracing it, which I can trace it all the way proximally into the spiral groove. But as I go down, the radial nerve kind of, becomes slightly more thinner, and then it bifurcates into the posterior, over here, posterior interosseous nerve and the superficial branch of radial nerve. So again, I go back to the capitulum, and this, again, I start tracing the nerve right over here, all right? So again, as I come down, this is the radius again that I'm looking at. This is the superficial head of the supinator. This is the deeper head of the supinator. And this is the nerve which I'm looking in the short axis. So as I'm in the supinator tunnel, you see that this is a posterior interosseous nerve that I'm looking at. All right, so this is the radius, that's the deep heads, that's the superficial head. And as I go distally, and this is the nerve which I'm looking at. I've come to the extensor aspect of the forearm, and this is what I see, that the nerve is kind of splitting, and this over here, I'm outside the supinator tunnel over here. Again, I go proximally. This is what the posterior interosseous nerve looks like, and that's what we look at. Now that I've seen the posterior interosseous nerve on the short axis, so on the short axis, what I'm really looking for is there a change in the filamentous pattern, that honeycomb structure? Is there a change in the caliber? So that's what I'm looking at. And wherever I see a change, what I'm going to do is I'm going to turn my probe 90 degrees over here, and I'm going to try and look at the nerve in the long axis. So again, this is the posterior interosseous nerve. As it enters the supinator tunnel, this is the superficial head, that's the deeper head, and this structure, what you see over here, that's the leading edge of the supinator. So if it's a fibrous edge, also known as the arcade of Frosch, you see that the nerve is kind of kinking over here, all right? And then you can follow this nerve all the way distally, and till the extensor aspect of the forearm. Yeah, so this is the distal edge of the supinator tunnel that we're looking at. So if there is fat around the nerve, it helps us get a better contrast and we can evaluate the nerve much, much better over here, all right? So we can trace it all the way down. So that's the posterior interosseous nerve within the supinator tunnel. And I look for if there's any space occupying lesion, if there's any kinking of the nerve, if there's any thickening of the nerve, and if I want to do a dynamic evaluation. So this kink is a normal imaging appearance as it enters the supinator tunnel. And if I want to do a dynamic assessment, what I'm going to do is I'm going to grab the patient's hand and I just need your help. Yeah. Can you just put the So again, whenever you get lost, it's a good idea to identify your bony landmarks and start all over again. So can you take the probe a little bit down? So tracing these nerves in the long axis is a little bit challenging over here because these are thin nerves and most of the times you would want to do, So now, so that's the nerve which I'm looking at. And what I'm going to ask him is to try and supinate. Yeah, can you try and supinate? So when he does a supination, you see that the nerve kind of, you try and look for a dynamic, relax, all right. So again, if he tries and does a forced supination, you'll see that there's more kinking of the nerve over here. So that's something which I'm looking for. So that's the posterior interosseous nerve that we're seeing again. And I can trace it all the way distally in the forearm. As it goes down, it drops over here. And I can, so it might be a little bit challenging to look at the posterior interosseous nerve in the mid forearm, but if you come to the level of wrist, you can identify the Lister's tubercle, and that's where you'll be seeing the posterior interosseous nerve right over here, right below the EDC. That's where the interosseous pin nerve is. Yeah, right over here, along the radial wall of the Lister's tubercle. So you can see it over here. And again, it goes proximally over the interosseous membrane. So that's as far as the posterior interosseous nerve is concerned. And of course, when I look at the posterior interosseous nerve, if I see a lesion, I'm also going to have a look at the extensor muscles of the forearm to see if there is any denervation edema or if there is volume loss as well. That's one more thing which I'm going to document that, because that's the end organ. So once I've seen this, I'm also going to look for the common extensor tendon, because when I'm asked to look at the, we identify your bony landmarks, that's your lateral epicondyle and the radial head. And it's important that the patient kind of keeps the hand flexed and the thumb slightly pointed upwards. And what I'm going to do is I'm just going to put my probe over here and I look at the bony landmarks over here, okay? So that's the lateral epicondyle over here, that's the radial head. And if you look at the bony cortex, this is what I'm trying to see. Look at the smooth cortex over here of the lateral epicondyle. You see that this entire structure over here, that's the common extensor tendon. And this deep structure which you see over here, that's the radial collateral ligament. Now, as someone who's just started doing MSK ultrasound, you might find it really challenging that, which is the common extensor tendon and which is the radial collateral ligament. So what you can do is, just as a rule of thumb, if we divide this into, let's say, proximal 2/3 and lower 1/3, the structure coming out from here, from the lower 1/3, that's going to be your radial collateral ligament. And as it goes around the radial head, and that becomes the annular ligament over here. But over here, the upper 2/3, that's going to be your common extensor tendon over here. And that's what it looks like. That's entire thing is a common extensor tendon. This is the enthesis where it attaches over here. This dark structure which you see, that's the fibrocartilage where the common extensor tendon attaches, all right? So we do these small movements. We look at the entire extent of the common extensor tendon. The reason why the extensor tendon looks echogenic is, because of all the collagen packed together. So in a normal patient, this is a normal fibrillary pattern of the extensor tendon. To a newcomer, you might find it difficult to evaluate the radial collateral ligament or differentiate between the two. But then this is the radial collateral ligament. It goes over here. It winds around the radial head, and this is the annular ligament that we're looking at. If you want to separate out the extensor carpi radialis brevis, you go slightly proximally. You lose that radial head, and right over here, what you see is isolated fibers of extensor carpi radialis brevis. You can have a look at that. This over here, slightly more proximally, this is your extensor carpi radialis longus muscle because it has its origin from further up. Another thing, slightly more difficult, if I may show, you can also have a look at the extensor tendons in the short axis. So once again, that's my lateral epicondyle, and this entire thing is a common extensor tendon. If I want to identify the ECRB, as you go distally, so this is the lateral epicondyle. I have lost the lateral epicondyle. I'm at the level of the radial head, and that's the annular ligament. And if you look at the muscles, this is also known as a scorpion's sting. It actually looks like a scorpion's tail. So this is the tendon of the ECRB, all right? So you can go all the way over here, and you can see, and you can kind of see it insertion right over here. So that's the ECRB tendon for you. So if at all you are planning to do any intervention, this is one good way of looking at the tendon. You can directly just target right over here. So that's as far as looking at the common extensor tendon and the radial collateral ligament is concerned. And yeah.
Thank you so much.
Yes.
That was fantastic. One point you note is they're driving down roads they know. And when you are not familiar with the machine and the anatomy that you're seeing, you'll feel very jerky. And you'll not see these images as clearly as you're seeing when they're driving. They're driving through roads that they know so easily, like it's the back of their palm. They know it perfectly well. So you need to keep doing this over and over and over again, maybe on yourself, maybe on assistants or whatever. But that's the reason why they look so wonderful when they're doing it. We are running a little short of time.
So he has a question.
Yeah. One question. I noticed that you were using it in the MSK mode.
Yes.
But when we are tracing the nerves, we've seen our anesthetists usually when they use the sonocyte in the theater, they use it in the nerve mode.
Correct.
So what is the difference and which one should we use when we are starting
so
off?
that's a very good question. So, this MSK mode, nerve mode, these are just names. All right, you can kind of make those presets. You can sit with the the technician, and you can set it according to whatever you like, and you can maybe name it whatever you want. So what we do is, we have 3 general presets as far as MSK is concerned. So we have a general preset, maybe it goes for large joints, hip, knee, maybe obese patients as well. And then we have another general preset for elbow or ankle. And then we also have a superficial presets, at least these are wherein you can see your nerves, like your digital nerves, your extensor tendons. So you can figure what you want, and you can name it whatever you want. You can name it as a finger or it doesn't matter. So, but then these are the presets which come with the machines, which can be altered.
So basically it means that within that range, the way you're moving your focal point,
Yes.
that's exactly what the presets are.
Yes. So the key is, you have to keep on slightly of kind of adjusting as well. It's, basically like photography. You want to shoot, you adjust your focus, you adjust your gain, and that's what it is, to get a good image.
Thanks. Yeah.
Yes.
What if you run out of jelly? Ellen has already told you, take a bottle of water, take a this thing of water. Jeff, can I request you to come for your lecture? We are running a little short of time. I'm not putting any pressure on the speakers. I'm going to put pressure on the delegates that you're going to have less time for coffee if you want to listen to them. So they'll continue into coffee time. Those of you who want to go and grab a coffee can grab a coffee and come back. And at the end of this session, the faculty members, please come quickly onto the stage. Before we hand over this hall, we need a photograph to be sent to the Central Committee of the Asia Pacific of the faculty that ran this course. Jeff.
How I use ultrasound.